Great. So I just want to take a minute here to introduce our presenter today, Dr. Elizabeth Barnert. We're delighted to have her join this morning. So Dr. Barnert is a pediatrician, and she's an associate professor and a researcher at UCLA. She's in the Department of Pediatrics at the David Geffen School of Medicine at UCLA. So she's joining us very early on the West Coast today. She provides clinical care at Juvenile Hall, and her community partnered policymaker engaged research examines health services and other systems of support for young people involved with the criminal legal system, an incredibly important topic. And so I understand today she's going to talk to us about community reentry in the lives of young people and some of her work in this area. So we will turn it over to you. Thank you so much.
Thank you, Lisa. It's really a pleasure and an honor to be here, and I really welcome feedback. I look forward to learning from you all and sharing ideas. I'm going to share my screen right now to pull up some slides. And then let me get it on the big view. Okay, you guys can see, yeah?
Yes.
Yes.
Okay, wonderful. So the title of my talk is I'm Good, Community Reentry as an Opportunity and Challenge for Improving. So as Lisa mentioned, I am a pediatrician and I do clinical work in juvenile halls. And then I'm also doing research to try to help disrupt cycles of incarceration and help set people on healthy trajectories. And so that has over and over again keeps leading me back to the issue of substance use, because that's what my community partners and the youth themselves are telling me, you know, the issues that they're struggling with that are causing some of the biggest setbacks. Okay, this is a brief background. Reentry has sort of been the focus of my work per the request of my community partners in Los Angeles County. African American and Hispanic young adults have a disproportionately high risk of incarceration and HIV, and these are outcomes that are fueled by substance misuse. This young adult population has malleability of brain development, and it's also a crucial time period in their social trajectory. So young adulthood is a very important time to intervene. Improving access to and coordination of substance use treatment and health and social services may improve young people's well-being across the lifespan, in particular when they're in this very critical, very, very challenging phase of returning home from jail. And what's crucial to understand is that the existing interventions that we have in the reentry space are not tailored to transition age youth. They're not specific to young adults. So I spend most of my time in the juvenile legal system, and it's a very harsh environment, but at least it's designed for youth. When you turn 18, and you enter the adult jail system, it's really a one-size-fits-all approach. And so the 19-year-olds are offered the same support or the same lack of support as a 50-year-old. And young people's brains are different and their needs are probably different. So that's kind of what brings me to my research focus. The objectives for this talk are to describe the health needs, service utilization, and predictors of successful linkages to care for transition age youth who are 18 to 24. And these are young people participating in a community health worker-based reentry intervention. And we're also going to talk about clients' perspectives about their health and social experiences during reentry to inform future intervention approaches. And then we'll conclude by discussing a model intervention tailored for transition age youth undergoing reentry, designed to address substance use, recidivism, and improve related health and social outcomes. So my main partner in this work, this is for my NIDA Career Development Award. I have a K-23 and I'm in year 4 of the award. And there's been lots of twists and turns related to COVID, but we have been chugging along. So my main community partner is the Whole Person Care Los Angeles Reentry program. And this is a reentry intervention funded by a Medicaid waiver. So everybody that's in Los Angeles County jails who has Medicaid or is Medicaid eligible is invited to participate in the program. Whole Person Care LA provides pre and post-release services to connect adults transitioning home from jail to needed health and social services. So as I was saying, kind of one size fits all approach. This intervention also, it's for everybody leaving jail. So there's not a specific programmatic focus on the transition age youth, but my focus for my study has been on this population. So the intervention has two main components, a pre-release component. So this is the component that occurs in jail, where community health workers meet the clients in the jail and they do a psychosocial assessment to develop a reentry care plan. The Medicaid application is initiated, so it can be activated upon release. In case you don't know, Medicaid gets turned off when people become detained or incarcerated because of the inmate exclusion, which is a big challenge in the reentry space, because people often will leave without Medicaid, even if they came in with Medicaid. In the pre-release work, they begin the process of creating linkages to community-based services such as substance use treatment and housing. And very importantly, a 30-day medication supply is provided, as well as continuity of care documents. And then there's a whole person care release desk. So this is like, you have to think like, oh my goodness, this is an extra intervention. So without this intervention, people will often leave jail with no support. So sent out at midnight out the front door with no money, not a phone number to call, anything. And then they, and then of course people come back. So the whole person care intervention has set up a release desk that as the clients are leaving, they'll help them arrange transportation, find a shelter bed, and then they'll also do as much as they can of a warm handoff to a post-release community health worker. And then the post-release component involves what happens in the community. So linkage to housing, employment, legal assistance, social support, accompaniment to key health and behavioral appointments, mentoring and empowerment, health and social service navigation, and connections to transportation. So this all sounds great, but what my community partners told me anecdotally when I was starting my K project was that as many as 75% of their clients don't make this post-release connection, that people, for various reasons, they don't know why, but they are receptive to the services in jail, but they are not able to have that first connection to the community health worker post-release. So a lot of my work has been motivated to try to figure out why and what's happening and how we can help with that. And so you'll see, I'll be talking about that more. So I have been really fortunate to have the great partnership of the Whole Person Care program, and they've given me access to their administrative data. So the electronic health record data for all of their clients in the program. So the entire program has something like 15,000 clients. The transition age youth, the 18 to 24-year-olds, comprise 12% of their population. And so I'm working with them on an analysis to see what we can learn about the transition age youth. So this is an example. This is the demographic information for the transition age youth in the intervention. So there's 2,905. And just ignore these second two columns, and I'll tell you why later. But just kind of big picture, we can see that most of the participants in the transition age youth category were male, Hispanic, and had a history of being unhoused. And I'm sorry, one second, I have a child visitor here. Sorry about this.
No worries.
What does Hispanic mean?
So I need you to go
What does Hispanic mean?
I need you to go right now.
What does it mean?
It means they're Latino like us.
Oh, okay.
Okay.
Well, it's not that common.
Thank you. Okay, sorry. Okay, so next slide. Okay, so this is really exciting to be able to see the morbidity. There's actually, as we have a one size fits all, we don't have published data in the literature on what transition age youth look like in terms of their health needs. This is actually new information for the field. And so the main point I want to make here is that among the diagnoses, the mental disorders were very high, 55%, and the substance use was common at 38%. Okay, so here, okay. So as I mentioned, I want to help my community partners and help the field understand what are predictors of successfully connecting to the whole person care intervention post-release to actually getting the help in the community. And so this is a model that we're working to build. And, you know, I really believe that statistics don't lie. And so when we looked at this model and it's not really showing anything, I thought, I really hypothesized that there are differences between who's connecting and who's not connecting. And so I said to our the UCLA team that's helping me analyze this, it's like, I think we need to go back to whole person care and ask them if we're making these categories correctly. And it turned out that we were not categorizing this post-release versus pre-release versus post-release. So this is kind of a work in progress. It turned out that they were labeling everybody as post-release when they know that they're leaving jail. But what we really want to capture is engagement, like that successful community health worker connection. And so we know how to do that now. Anyway, so I think we will be able to show a model of who connects and why, and also to use descriptive data to try to answer in detail this exit reason question, which won't be in the final model, but exactly the different reasons for why people are not connecting. So I'm excited to be able to share that soon. And feel free to pause me if you have any questions. So this is the health service utilization data. So adjusted rates of healthcare visits pre and post enrollment among all of the clients, all of the transition age youth clients. And so the data, the findings look really good. And honestly, I need to think about this more. But what we can see is that the preventive care visits increased. And the kind of care that you prefer not to have happening, such as medical inpatient visits, ED visits, decrease. So whereas primary care specialty increased, psychiatric inpatient visits decreased, and then the ED visits, as did ED visits as well. So we're going to be getting criminal justice data probably that we can add to our adjustment, but honestly, oh, sorry, did the slideshare just go away? Yeah.
We can still see the slides.
Oh, now you can see it. Okay. So anyway, it looks really good, but I need to understand this better in terms of so many participants not successfully connecting post-release. So what is working and why? So we're looking into that more, but it does show that that intervention, I think, is likely to be helpful. I'm a harsh critic. Okay, so I'm going to shift now to talking about some of the primary data collection that I've done with this population. So in addition to looking at the administrative data, we have been doing outreach to the participants themselves. And so it actually took a year to get all the approvals in place. We were up and running. We were in the jails recruiting participants from this whole person care reentry program. And this was in March 2020. And then we had to pause because of COVID. And so we had 19 participants in that initial cohort, and then we adjusted to do remote recruitment after that. But I'm just going to show the data from the 19 because this is what is kind of most clean and ready to talk about. So the main finding, the participants were all male, and that is because we began our rollout in the men's jails. And so that was as expected, and we weren't able to get to the women's jails before COVID. And then otherwise, the demographics look similar to the larger sample. I think it's notable, these are 18 to 24-year-olds, and half of them have children, and a significant number are in a committed relationship as well. Oh boy, okay, this slide. So one of the things we did, so this was my team would go to the jails invite people to participate in the study and administer the survey in the jail. And we asked people, we gave them a measure of their adverse childhood experiences. And this is the kind of classic ACE scale without some of the without some of the abuse questions for issues of sensitivity. But the main finding is that exposure to childhood adversity was very high. So on average, participants had 5 ACEs, reported 5 ACEs, and the range was 1 to 10. And I want to just point out that 74% reported that their parents or guardians were separated or divorced before they were 18. And more than half reported that they had lived with someone with a drug or alcohol problem, 63%. So I think one of the things I've observed in the field of pediatrics, and specifically in the field of youth justice, is that there has really been a growing recognition in the last decade and a half or so of the need for trauma-informed care and for recognizing the extremely high burden of ACEs in the youth justice population. And I think that this is really going to be really valuable for the field of the adult criminal justice, and especially for young adults, if we recognize the childhood trauma and the ongoing trauma of these young people. I'm going to talk briefly about the qualitative interviews we did with the participants later, but it was really striking to me how much you could see they were actively processing their prior trauma. In my clinical work, in LA County Juvenile Hall, a couple of months ago, I met a young man who was incarcerated in juvenile hall in the camps for many months, was due to be released. The week before his release, he got an infraction. As one of my colleagues put it, he was trying to sabotage his release. And so I saw him for a Friday on, it was this kind of odd scenario. It was an intake assessment, even though he was already incarcerated. And the reason is because he was turning 18 the next day. And so the plan was that he was going to serve his new stay for his new incarceration in jail. So I saw him on a Friday. I wished him a happy birthday. And then when I was doing my exam of him, he had told me during our history that he's in gangs. He doesn't see a way out of gangs. When I was examining him, I got close enough to him to see a really elaborate, incredibly artistically done tattoo on his hand. It was a portrait of a little boy with dates, like dates of death. And it was his little brother who had been killed, I think at about the age of 10. And I looked at him and I said, "This is why you can't leave gangs, isn't it?" And he just kind of nodded. And so I think my point is that I think that this is a big part of the story. I think I really want to push the field, encourage the field to think of these transition age youth as young people, as this kind of next step of they used to be an adolescent and their brains are not that different from when they were 17. And to think about, a bit more about their family background and their childhood trauma. Okay, so back to the surveys. In terms of the mental health data for the 19 people we've interviewed, these are some of the mental health data that we have. So 37% of the participants reported a mental health diagnosis. 20% said they were currently taking a psychiatric medication. And this is really interesting. So 53%, half of our participants, more than half, said they plan to see a mental health professional once they were released. So these young adults are wanting to access community mental health support. And this is actually quite common when you look across the reentry literature, in the youth reentry literature, that young adults really desire change. They're motivated to succeed, and they say they often plan to succeed. And then things just are very difficult upon release. And this just shows our sample had, not unexpectedly, a pretty extensive history of justice involvement. So they had spent some of them had spent up to 5 years in the youth correctional system. And lifetime number of arrests ranged from 1 to 38. So it was sadly, I think, fairly consistent with this jail population, which tends to be sort of revolving door of arrest, incarceration, release, arrest, incarceration. So in terms of substance use, this is kind of just the tip of the iceberg of some of our substance use data. So yes, they had a lot of high rates of ever using alcohol, marijuana, and illicit substances at 84%, and a fair amount of 30-day substance use with alcohol and marijuana. Sorry, I didn't put the data here. And then I also want to point out that 68% said that they considered themselves to have an addiction. So again, the people seem to be recognizing patterns of behaviors that they feel are getting themselves in trouble. And even though 68% reported addiction, only 37% said that they'd ever been in substance use treatment. And then 13 of our 19, 68% said they plan to receive treatment once released. So again, there's this kind of hope and desire to access community behavioral health services. And so back to this question of who falls through the cracks and why. So with the more robust data, I hope to be able to build that multivariate model. And then I'm going to show you some qualitative analyses as well. And then right now, it's actually very exciting. This is the recommendation of our community advisory board when we had to shift trust, as you can see, and I'm sure you won't be surprised with the data that I presented. Trust is a really big issue in this population. And so it was great when we were in the jails meeting them in person. And then during COVID, we switched to remote recruitment, and it was hard to get our enrollment numbers up. And so we asked our community advisory board for advice. And they suggested that we go back to these participants, to these original 19 participants, and ask them and future participants to help us with enrollment. And so we're actually doing a snowball enrollment process, and I've done snowball recruitment many times with qualitative research, but this is my first time doing it with quantitative research, but it's going very well. And it's going so fast, we're very busy. But basically what happens is after a participant has participated, completed a survey, received an incentive, we say, do you know anyone who is 18 to 24 and was probably just as involved? And if they successfully give us a name of somebody and that person contacts us, then they earn a $20 referral fee. So it's been going really well. And sorry for that jump. And we have been quite busy with that. So we've been following our participants longitudinally as well through the 6 months of the reentry period. And I have not had a chance to analyze that data yet because it's going so quickly with the snowball recruitment. But what I can see from looking across the longitudinal data through the 9 months is that our participants seem to look progressively more healthy, less substance use, kind of more hallmarks of reentry success, like successfully enrolling in school and getting a job. We do have a fair amount of attrition. So I think that our participants are probably looking more healthy a bit because of, they have passed the reentry phase, which is so disruptive. They're more stable, they're more on their feet, but I think it's mostly the effect of differential attrition that we're seeing people who are doing the best. So again, this makes me really concerned about who's falling through the cracks. Why are 75% of this great whole person care intervention clients not connecting? And who am I not retaining? I should tell you also of just this 19 participants that we were giving $50 incentives for each survey and each follow-up survey. None of these 19 participants connected to the whole person care reentry intervention post-release. So there is a disconnect that seems to need to be addressed for these transition age youth. So one of the really pivotal moments for me in the study was in March 2020. We were scheduled to have our twice yearly community advisory board meeting. We have a great community advisory board meeting comprised of people with lived experience of justice involvement who are community leaders from organizations that serve young people during reentry. And I thought that they would tell us to pause the study, that what everything is, what they were dealing with and what the young people undergoing reentry are dealing with is just so challenging that, UCLA researchers get out of our way. But they actually said the opposite. And that was really eye-opening for me. They said, we need to know where these young people are at. We need to know how they're doing. Please continue. And so we listened to them and we got an IRB amendment. And, it takes a long time to get IRB approval to be able to access these populations. And there's also the approval with the jails and the county. It's very hard process. And so we were actually I feel like we were really lucky in that way to be in the right place at the right time. And so in our amendment, we got permission to interview the 19 participants monthly, to just talk to them on the telephone and ask them about their behavioral health, ask them about their reentry processes. And then we also augmented the sample with another reentry organization in the community. And so I'm just going to briefly share with you, just to bring their own voices to light, some of the findings from the 3 qualitative analyses that emerged from that work. So the first one on experiences of reentry during COVID, the main finding was that the transition age youth shared a wide range of beliefs regarding COVID, but overall, they felt that the reentry was more urgent than the pandemic. And it was so humbling, but it really indicated the immense challenge of navigating community reentry after incarceration. So as this one participant said, I think my experience was different because when the pandemic was really broke out, I was in the hospital recovering and then rehab recovering. So I didn't really have that effect or not, like telling us we're in lockdown, we can't do this, we can't do that, because I was dealing with my own personal issues at the time, and the pandemic was the least of my concerns. These young people really are going through a lot. There's a lot of developmental tasks, a lot of social tasks of young adulthood and of reentry, and of behavioral health, and trying to not re-engage with substance use. And so this really, it made sense. The time period for these interviews was June 2020 through these 9 months of interviews. And so that meant we were talking to participants who were all Black or Latino. And so we also asked them about their views on Black Lives Matter and the criminal legal system. And so the TAE overall agreed on the presence of racial injustice in the criminal legal system, but some of them supported the protests and others didn't believe in it as a method of change. And then they all expressed little hope regarding potential reform or change in the criminal legal system. As one participant said, it's not going to stop. It don't stop. It's not going to be fair ever. Another said, he was speaking to my a graduate student researcher who's Black also, he's Black, because us, we have no power. So at the end of the day, it's nothing we can really do about it. And this was a participant who was disagreeing with the protest. Well, of course I support it, the Black Lives Matter movement, because it's people with the same skin color as me, but it's crazy. The protest, at least, the protest is crazy. And then the analysis, this is the one that we are, I would say, kind of 3/4 of a way through our analysis. We're looking at how how the young adults think of their own health in reentry. And our main finding is that they consider themselves to be mostly physically healthy, and that aligns with that list of diagnoses I showed you from the electronic health record. And instead, they center their conceptualizations of health on their behavioral health progress, particularly with regards to substance use, and then other challenges and changes that they're trying to accomplish related to their reentry success. So we're trying to look at how their conceptualizations of health relate to their criminal justice involvement and really trying to understand where they're at. So as one participant said, lately I've been doing pretty well. I've been dealing with my anxiety a lot easier. So I've been kind of sober and I'm just getting back into the daily routine of, having a life again. And don't get me wrong, I still have my urges and temptations to go back into old habits, but nonetheless, I got to fight. I've been feeling a lot better. So across all of this work, the conclusion so far, I think, is that transition age youth have high stake needs and interventions tailored to them may be useful for reducing substance use and recidivism, as well as improving related health and social outcomes. And that practical support from trusted individuals. And just to pause here, we've been measuring their social networks. I didn't show that data, but a lot of the participants either said that they don't have anybody to rely on, or they do have people to rely on, but their social networks involve people with high rates of risky behaviors, of substance use, criminal legal involvement themselves. So practical support from trusted individuals during reentry designed for transition age youth that is adaptable and responsive to their needs and their perspectives to improve linkages to care is urgently needed. Another thing that was a really interesting phenomena, kind of natural experience, I should have mentioned during the COVID analysis, was that one of the things we saw, COVID was hard on our participants, particularly for our study participants who were following, who were unhoused or were trying to get a job. But there was also this unexpected phenomenon of because of COVID, they were in lockdown. And because of that, it led to them to reconcile with some of their relatives, with some of their parents, which then decreased their substance use because those positive social connections were strengthened. So that was really fascinating to see. For me, this was my first time working with transition age youth. And the extent to which their parents were a crucial figure in their lives, even though these were young people with substance use issues who were coming on and off the streets. A lot of them actually had a family member that can potentially be leveraged, I think, in partnership with some kind of community health worker intervention to help people address the challenges of reentry. So, putting that all together, what next? So at this point in one's career development award, we're encouraged to write our first R01. And so I was thinking about what have I learned so far, and what do these young people really, really need? And so next step was to go back to the literature review and see what had changed since I'd written my career development award. And I found a conference abstract from the an American Public Health Association annual meeting of a re-entry intervention designed for transition aged youth. And it was exactly what all of my data point to, which was needed. It was developed by Vicky Ojeda at UCSD. She also had a career development award from NIDA and was just sort of 5 to 10 years ahead of me in the process. And so since then, her program description papers have come out, and Vicky and I developed a partnership, and we've been working with Steve Shopta and Madhukar Trivedi from the NIDA Clinical Trials Network to develop a proposal that we're hoping to submit through the Big Southwest node. And I'm so excited because this does so many things to address so many of the issues that I've learned from my study participants and through the Career Development Award. So that's what I'm just going to devote the remainder of the presentation to talking about briefly. The Relink is the name of the intervention, and it's a health coaching intervention tailored for transition aged youth. The novel Relink health coaching intervention was successfully piloted with over 140 justice-involved young adults. That's the acronym that we're using in this because the age range, we've raised it to 28. And it has demonstrated improved health and social outcomes. So it reduced anxiety and rate of uninsurance and recidivism with data from probation. and it was associated with improved healthcare use, employment, and food security. And so this is the conceptual model for the relink intervention. And just for the sake of time, I won't go over it in detail. So the specific aims of the procedure, of the study, another visitor, would be to assess the effectiveness of relink in improving justice-involved young adult substance misuse and related health and social outcomes. And so for the aim 1, we would use a multi-stepped wedge design to assess the impact of relink versus usual care on the justice-involved young adults, substance misuse, substance use treatment uptake, recidivism, HIV and STI risk and prevalence, health and social service use at 6-month follow-up. And then aim 2 would be longitudinal interviews over time to explore satisfaction with relink, effects of relink on substance use, recidivism, HIV, STIs, self-efficacy for accessing services, and this nifty component of diffusion of health literacy skills to social contacts. And so the innovation is that this would be a novel health coaching intervention designed, I slipped in the other acronym, for TAE, experienced substance misuse, criminal legal involvement, and elevated HIV, STI risk. And I've already kind of gone over the approach, but the idea is that we would look at 5 sites to recruit 300 participants with 60 participants per site. And just a bit on the intervention, I want to save time for questions, but so the intervention is a coaching intervention with personalized health coaching and service navigation to engage clients in goal setting and problem solving. And so clients meet weekly with their health coach and they complete a 12 model curriculum. And then there's also a service navigator who meets with participants for 30 minutes weekly for 6 months to provide referrals and warm handoffs to health and social services. And the adults with lived experiences are the navigators who are also modeling pro-social behaviors. And this can be delivered in person or virtually. So the inclusion criteria would be 18 to 28, history of justice involvement, substance misuse in the past year, not being incarcerated at enrollment, and ability to provide informed consent. School starts soon. I think we're in the clear soon. And the methodology would be surveys at baseline and follow-up at 3 and 6 months, testing for substance use and HIV, STI at each visit, and then a subsample would complete the qualitative interviews. And the primary outcome would be at aim 1 is recent substance misuse at 6 months, and then we would look at all of these secondary outcomes. And the quantitative methods would be to compare outcomes between the intervention and control arm with a generalized linear mixed model with terms for treatment groups, covariates, cluster effects, and possible calendar time effects. And also we would have to be very thoughtful about the different site selection and do measurements to try to capture differences in implementation across this in context across the sites. And then the qualitative methods would be a subsample of 60 individuals proposively sampled, and then we would do a thematic analysis. So that's what I have for you today. It's been really wonderful, honestly, to put together this presentation to help me reflect on my learning journey as a case scholar, and then very humbling to put together the list of all of the wonderful people and organizations that have helped me in this work. So I really thank my K mentorship team, especially Mitch Wong, Chris Grell, and Joan Tucker. Some of you may know them. This is my boots on the ground K23 study team, the whole person care LA program, and the analytic team, the Reentry organization, New Earth, for their partnership for the qualitative interviews, my amazing community advisory board, who has truly made an impact in guiding the study, my program officers at NIDA, California Community Foundation, and my new collaborators with the Relink proposal. And thank you all so much for your attention and for the opportunity to present to you. I really look forward to your questions and ideas. Thanks so much.
Thank you so much, Liz. That was terrific. Such important work, and this project idea you have sounds terrific and incredibly important. So any questions or comments, feel free to just unmute yourself and jump right in.
Lisa, just to unmute, because George Woody here in Philly. The issue, the comment you made about people being released in the middle of the night is sort of interesting. I think that has to do with when they make bail. They don't want to, as soon as they know that they made bail, they leave. And sometimes they don't find out until like 10 o'clock at night, at least in Philadelphia with adults. So I always wondered if there's some way to sort of coordinate that, because they release people in the middle of the night and then they have no place to go. They're on the doorstep of some neighbor to the prison. And it's just a comment. It's sort of an issue that would seem to be corrected.
Exactly. There are so many solvable issues. And other thing, when at the very beginning, when I was talking to my community partners with whole person care, 75% don't connect, and what's going on? And they say, well, you ask people phone numbers, and people don't know phone numbers anymore because everybody has, their cell phones. So we don't memorize phone numbers. And so people have their cell phones that are taken away. And then during their jail stay, their cell phone battery has died. And so when they leave, it's really hard to know who to contact. And so you're exactly right that, there's some very important, deeper structural issues of systemic racism and wealth inequality to address that are feeding these problems. Sure. But there are some very immediate logistical things. And so, one of the things about this intervention, I guess it's good to acknowledge your biases as a researcher. And, I don't know the specifics of what the data will show, but it seems clear to me that there are some very basic things that should be standard of care that we're not doing, that we should be doing, particularly for the young adults, the younger people in the jail population.
Yeah.
Thank you for your question and comment.
Good.
As part of the services that people get linked to, if they have an opioid use disorder, would they be linked to medications for that as part of treatment for that?
Yes. Yeah.
As part of the care model?
Yeah. And so, and one of the things, this 30-day medication supply is really excellent because people are leaving with paper prescriptions.
Mm-hmm. Yeah. So you would have it set up, maybe, I'm sorry if I missed this, you'd have it set up where you'd have community partners sort of ready to sort of accept folks upon reentry, or?
Yeah, so the way whole person care works is it's contracting with an intensive case management agency. And so the community health worker is kind of embedded in that and bridges people and would accompany them. So if somebody needs to go to an opioid use disorder treatment clinic appointment, that's the kind of thing that they would be accompanied to.
That's great. That's great. I think that I'm glad you're going to put this in as a CTN concept proposal, but this also might be of great interest to the JCoin network at night. I don't know if you've chatted. I saw Tisha Wiley was one of the folks on your last slide there. She heads that up, but this seems right up their alley.
I didn't know Tisha was heading that. I have a proposal under review with the JCoin network.
Okay. You do? Okay, good. Okay.
Yeah, it's back with my the juvenile justice kids. It's about girls. So there's this other issue because I guess my charge, I really try to I want to get the care. So it's like the frame of a pediatrician, right? My job is not to treat the substance use disorder. It's to get the young person to the treatment, to the specialty care that they need. So with the JCoin proposal, the issue that it actually hadn't been talked about for a long time. And is we think about incarcerated youth, people who are actually detained, but there's actually a much larger percentage of young people who are justice involved and are in the community, who don't get the healthcare that me and my colleagues can give them when they're actively detained. So that's what my JCoin proposal is like. But that's good to know, to think about this for JCoin too. I appreciate that suggestion.
Yeah, from what I've seen in JCoin thus far, there's a lot of great and very important projects happening there, but they're very adult focused heavily. So the opportunity to focus on sort of the young population you're thinking of is great. I think it's considerable. Yeah.
That's good to know. Sorry for my Zoom visitors. I lost because I was slide sharing. I couldn't see the mute button, but and then I didn't want to comment. This is a parenting thing, right? What my son did was he took down his sister's art behind me. I commented. He just left up the one he made.
I saw one just
Pretended I didn't
disappear
notice.
there. That's funny. So, I was just thinking the bigger picture, what for the young population that you work with, this is beyond the scope of your project. I was just wondering what the statistics are. So for that young population, upon reentry into community after a period of incarceration. So what do we know is sort of the typical course? Like, what do we know about, the percent that get gainfully employed, or what do we know about the percent that sort of, relapse? Or, what do you have a sense of that for that young population? And I know these things are challenging for anyone who's been incarcerated, but is it particularly challenging? Are the statistics particularly concerning for this young population relative to their older adult counterparts?
Great question. I don't know. We don't know.
Okay.
I think what we have looked at for reentry typically is just that criminal justice, data of recidivism. That's what people have been focusing on. And so, but I have not seen kind of reliable estimates even of the simple prevalence of substance use disorder in this age group. So yeah, you make a really good point about tracing out the pathway. I think what we're seeing is that these are young adults who are essentially trying so hard to get their feet, on the ground, to get a job, to be in school, to kind of do all that developmental stuff. If you have young adults and then many of them are already parents and they have, this trauma and the substance use issues. So you kind of see these patterns of relapse and reincarceration, but I don't know the numbers, and I believe that they're not out there.
And sorry, I have all kinds of questions about just the system. So you were commenting in the beginning of the talk about how distinct sort of a juvenile, detention facility is. And then on their 18th birthday, sort of they're treated like, if they go into the adult facility, they're treated like any other adult, no matter what their age. What are the main differences in the youth facilities in terms of how they function, or what more developmentally appropriate kinds of things do they do or offer? I'm just curious to understand the system a little bit more.
Yeah, no, those are great questions. So one really active policy issue is this issue of transferring children to adult facilities. So there are a number of states, New York, for example, used to have an automatic transfer, and a lot of states still do, that anyone who's 16 and older would go to the adult system. So we do have kids that are less than 18 who are in adult facilities also. But in terms of the difference between the system, in essence, the juvenile legal system was founded in the early 1900s with the recognition actually that children's brains are different. And so children should be treated differently, very much with kind of a social welfare approach of how do we help these children? How do we rehabilitate them? And so they have access to school. There's only other young people. There's kind of this, not as much as when they could, but their parent engagement is, a part of the process. Whereas on the jail side, these are adults. And so we're not talking about their parents or caregivers anymore. And that's why this is one of the surprising findings for me, is like, wait a minute, they're saying like we had one participant who, when we call him, we have to speak to his mother. He said, I was having lots of substance use stuff, so I can't access my cell phone. I don't have my access to my cell phone anymore. My mom does. So to call me, you have to call my mom. So anyway, so parent engagement is a different piece of it. And then there is an effort to, somewhat make it youth focused. And then there's I see a lot of kids get in fights a lot, so they're tired, they're hungry, they're cold, they're upset, they're stressed about their court dates. There might be gang rivalries. And so there's this kind of, they're being around other kids is really important. Whereas when you turn 18 and you're in jail, it's a whole other thing. And you're around adults, big scary adults. So that's another piece of it. But conceptually, the juvenile legal system is supposed to be more rehabilitative. It's hard for me to say that because so is jail, but we're even farther from doing it there.
And is the juvenile legal system, does it routinely offer all youth the chance to get a high school diploma equivalent while they're incarcerated?
Yeah. So there's everybody has access to school and everyone has access to healthcare by law. And not surprisingly, the quality of the education is not very good. So it often turns out to be worksheets. And then a number of kids do complete enough courses to get a GED, and it's one of the benefits of incarceration. It's hard, but it is good that they have access to schools. That was one of the really big challenges in the pandemic was, became even more isolating when they couldn't even go to their schools.
Yeah. Sorry, I don't mean to ask all the questions. Feel free.
I love it.
To jump
Go
in.
ahead.
And feel free to unmute and jump in if you want to ask any questions or make a comment. Liz, if your study idea gets funded that you shared with us, I think you'd have a lot of sites very interested in partnering on that.
Oh, good.
Yeah, I do think so. I just know we've been part of the J-Coin network as well, and it's an amazing network. And I think, that network for sure would be really interested in this, the sites and just the needs for young people is so overlooked so often. So I think that, maybe you've got your sites in mind already, but if you don't, I think you could probably find some pretty readily.
That's great. No, yeah. We don't actually. We just kind of are conceptually, thinking we're trying to aim for something generalizable because as I kind of said, I'm like, it's time for this to be standard of care. So we want something that would give us national generalizability. But we don't have specific sites in mind at this point.
So I know you said you discovered sort of this abstract for a conference and learned of this sort of model in this work. What can you just summarize a little bit more? Like, what are the main empirical data thus far that show the effects of that model?
It was astounding. So I had a phone call with Vicki before her program description paper was up. And as much as you heard me touting like, oh, criminal justice data, we just look at recidivism. That is kind of the gold standard when you're looking at this data. And she actually had from probation a significant reduction in recidivism associated with participating in the program, as well as I don't have the rates memorized, but as well as decreased substance use and then increased successful engagement in services. It was like wow, this thing really works. And I see the proof of proof of concept and the ideas of what you're actually doing for these young people. It's amazing.
Yeah, that's great. All of those any of those outcomes would be terrific to impact, but those are multiple impacts there. That's great. Really important effects.
And it makes sense, right? Like if these young people, they really need that hand holding for that basic stuff, like turning Medicaid back on, scheduling those first appointments, transportation. Yeah.
Even older adults coming out of incarceration need that too.
Yeah.
The study we're doing with J-Coin is starting medications while long-acting formulations of medications while people are incarcerated, and then linking them to treatment back into the community. And it just the challenges people face when they get into the community, it's just heartbreaking. They already, have this record making it very difficult to get, a job, but then all the housing challenges and the challenges with substance use risk and, and economic challenges. I mean, it's just people are set up for such big hurdles to overcome.
That's great. I didn't realize you were doing that. That's wonderful.
Well, we're not leading it. Josh Lee, who's I don't know if you know Josh Lee's work. He's at NYU. He's the lead PI, and then there's 5 states around the country that are partnering on it. And so we're one of the New Hampshire is one of the states. So, yeah.
That's great.
Well, thank you so much for sharing this with us. When you have some data from hopefully your soon to be funded project, to come back and share it with us.
I would love to. Thank
Yeah.
you so much for
Great
hosting
work.
me and for the opportunity to share this work. As you think about your work on this bigger project, think about like 25, or there's different places to put the cutoff, but think about like just taking a lens and zooming in on how your young people are doing and if they're different.
Yeah, it's a great point. It's a great point. We will. Yeah, thank you for that.
Okay.
Okay.
Wonderful.
So,
Nice to meet you all.
you too. Nice to connect with you. Thanks. Hope we stay in touch.
Bye. Yeah.
Bye-bye.
Thank you, Lisa.
Thanks.
Bye, Chantal.
Bye. Bye,
Renee.
Liz. Bye.
Bye. Thanks.